quirky nuances. This one doesn't have it, but it's similar. I think the reason to show you this is because it's similar to the way the interventional guys have their tubes, with like a key difference. Okay, so this is a pigtail. If you get this little inner obturator hooked on here, this isn't something you guys will be doing, but it's just to make the point that it doesn't come as a pigtail, it comes straight, and when you pull the obturator out, it makes a pigtail. The interventional radiologists have pigtails that have an inner string. Okay, so there's a string that helps form this pigtail, and if you go to try to pull that without cutting that string, and that's why their staff usually does it, you try to cut it without the string, you can't pull it because it stays as a pigtail. It doesn't come out the tunnel unless you cut the string. So if you're ever in that situation, the way to do it is to basically cut the tube through the tube, transect the tube completely. That'll release that string. The tube will straighten up, and you still have plenty of length of tube to pull out. So that's kind of the point for that.
Is that a tube you would use with your open heart patients, or more for
This is a tube you
lung?
use for thoracic patients.
Okay.
Like if you had somebody with an empyema who's getting TPA for treatment of that, or if you had somebody who came in with a pneumothorax and they didn't, they put in one of these smaller tubes, or we put in one of these smaller tubes with an ultrasound. It's a lot less traumatic because you're not doing a big kind of cut down incision, and they're more tolerated. I'd say they're better tolerated for longer duration after the procedure. They can go home with them. You can hook them up to things. And that's what the radiologists will routinely use, is these kind of pigtails. It's just a different delivery, and they have that little string on the inside to make it stay as a pigtail. This kit goes over wire, so that's what's cool about it. I mean, you make a very small incision, you pass it. It's just like you were putting in a line, like I don't know if you guys have done that sort of training where you put in central lines or things like, or arterial lines. They go over wire, Seldinger technique. So this is the same way, Seldinger, and then you put a dilator, and then you put the thing through over the wire. Let's see, here's your flutter valves. This was something that I came across in the circuit, and some of the guys do it different than others. This is a one-way valve, so the blue is supposed to go towards the patient. If the blue doesn't go towards the patient, you're blocking the suction that you might be hooking to from draining the air from the patient's chest, because this flutter valve on the inside, it's like a little piece of plastic. It only permits air out but doesn't permit air back in. So I usually tell people, if you have a chest tube patient that comes to the floor with a circuit and they have this little one-way valve in the tubing, in the circuit tubing, take it out because it's confusing. So just simplify the circuit as simply as possible. And that is to say, when you hook this up to the pleurovac, you just want tube to tubing. You don't really want to see tube to flutter valve to tubing, because there can be issues with that. And I've seen it where this will be in the circuit covered with tape as a connector because it's not really a great connection, and you're in the ER or somewhere where they don't have the zip ties, covered with tape and placed the wrong way. And so if it's the wrong way, you're not doing any favors for the patient. You're actually doing the exact opposite, because you're preventing the airflow the wrong direction. I would say if you see this in the circuit, and I know I've talked to the interventional pulm guys, and they do use this. I'm probably gonna try to advocate that we don't use these in chest tubes, just because it can be confused. That's the only reason. What else? You got tubing clamps. That's a good point. So when you're removing chest tubes for thoracic patients, for lung patients, and they've been to a circuit with, suction, you always have to make sure that before you pull the tube out that it's not on suction. I mean, it seems intuitive, but it happens a lot. One way to assure yourself of that is to use a tubing clamp. Another way to do it is some of these kits have like a 3-directional stopcock, and this has a little label that says off on it, wherever that arrow is pointing is off to whatever you're going to. So if this is pointing to the patient, that means it's off to the patient, and that's always safe. That's the same as putting a clamp across the tubing. That's something that probably you don't have to manage yourself. That's, you can call one of the docs and just say, hey, is this right? If you're not comfortable. Because there's, again, different ways that this can show up. But the smaller tubes tend to have these 3-way stopcocks. The bigger tubes don't have the tubing like this, and so a tubing clamp is safe, or just make sure you're off suction, so it's just passive drainage. What else?
How would you like for them to dress the incisions after? Just a sterile 4x4?
Simple as possible.
Okay.
When you get these folks come up through the ER, and no offense to anybody who's going to be an ER nurse, you don't need to cover everything with tons of sticky tape, because it just creates discomfort for the patient later. And it's not, we don't use Vaseline gauze. I know that was something that came up. We used to use it on trauma, and there was never ever any evidence for that. And the reason it's used in trauma primarily is because when you're in the trauma bay during a resuscitation, you end up doing like what you think is a 1 centimeter incision to put a chest tube in, then that becomes like a 5 centimeter incision that's tunneled and not pretty. So you stuff it with Vaseline gauze. It does provide some occlusive protection that way, but for the pulmonary and thoracic and IR folks who do these procedures, it's gonna be a controlled situation that doesn't need any kind of big, fancy occlusive dressing. I'm all for simplicity because I think it makes people comfortable. I think the patients appreciate that, and a lot of tape is like extremely uncomfortable, and it's one of the biggest complaints that we get when we're dealing with wounds and wound care is just how uncomfortable like taking tape off is, and we just don't need to add that to it. So 4x4s in a tegaderm seems to work pretty well, or 4x4s in whatever paper tape you have. This Medipore tape is expensive relative to some of the other options, and it's really sticky. That's my opinion. I don't really care a ton what people do, but I do think that those are the considerations: is patient comfort and how much it costs.